Welcome all to our February edition of the TB Think Tank webinar series. And this session presents a pediatric TB virtual ward where they'll be putting guidelines into practice and with real patients. And this will be presented by Drs Juli Switala, Juaneta, Luiz, Sipho Nyathie, and Karen Dupree. So I will now hand over to our presenters today. Over to you, Julie.
Thanks, everybody. I think we're not going to do a whole round of introductions. We think you know our faces very well by now. I think then we can pretty much start. So just how this is going to happen. We really wanted to make this an interactive session, so you can't just sit and listen, and you don't want to just listen to us. We want to hear what you think. So we've added a lot of polls. Please give us some patience and forgiveness. It's the first time we're running a session like this, so we'll need your patience. But the cue for you is that anything that's in orange is something where a poll is going to come up, and anything that's in purple, we'd love you to give us some answers on the chat. So as a team, we'll be moderating the questions and giving your feedback and sort of going as we go from there. So we've got 5 great cases for you. And all of these are real patients that have been shared via WhatsApp groups. And I think the reason why they're important is we're really proud of what we've come up with as the Child and Adolescent Working Group in terms of the guidelines and the quick reference guide. But sometimes when it gets to a real patient, it's not always quite so clear. So we want to help with that. Okay.
Thanks, Julie. Do you want me to take them through the names quickly?
Yes, go ahead.
Yes,
I'll just get my presentation up.
Perfect. So just to gauge, because we know the invite went out to multiple groups of people outside of the think tank as well. So we just wanted to know who you are to sort of know exactly where to pitch our discussions. So if all of you could please start. So this is our first exercise. You'll see your first poll on your screen. And if you can each please select an option there that best describes your current role. Then we can get a good idea of what our audience look like today.
I'm just waiting for my slides to go up while you're all voting.
Let us know in the chat if you're struggling, because I see there's only 4 responses yet on the poll. So if you have any challenges with, can't see the voting poll.
If you go to your chat, sorry, Karen. I think if you go to your chat and scroll up, you can actually see the history. If you scroll right up to the top, there is a question that says, "Who are you? Please let us know who you are." And there's a section where you can click submit vote. If it's not available, perhaps we can reshare it because some may have joined after that shows in the chat.
Maybe I'll just put it at the bottom again. Sure.
Can someone who was previously not able to see it, can they confirm that they can see it now?
I'm wondering, Nolwazi, if you could.
Okay, yes, they can see it. Oh, I'm getting yeses and nos. Can see it now.
Yeah, so there's a couple of people responding now, actually. So I think it's kind of getting there.
The numbers are going up slowly, so.
Yeah.
And for anyone who's joined late, the first step of business is we'd like to know who you are. So if you just go into the chat, there's a poll there where you can fill in what type of healthcare worker you are or why you are joining us today.
Okay, for those that cannot see the poll at this moment, it might just be because it was posted before you joined. Just even in the chat, you can just write for us. Julie, maybe just put the options on.
Oh, sure. Okay, so we'll move on. Those are the questions that we want to know. If you can't access the poll and you really want to let us know who you are that you're representing, you can just put it in the chat as well.
we've got 89 people within this call. There's 14 responses on the poll. So it does seem that there's a couple of coming through, ComServe, MO, specialist pediatrician, Peds ID. So it looks like we actually have quite a wide range. If I quickly scan, we've got some nurses, some medical officers, some pediatricians, other specialists, also some non-clinical program people, which is great. So we really have quite a wide audience today. We're talking to Julie, which is very exciting. And right. Please don't feel intimidated by anybody in the audience. I think the whole idea of this is to really show you that sometimes it takes a network of people to manage a child well. I see somebody has a hand up, but I don't think we can allow mics unmute. Can you maybe type in the chat for us? Is that possible?
I'm going to move on. It is up to you guys if you'd like me to unmute or not.
In the interest of time, I'm just worried. So if somebody's unable to, okay, perfect. So I think we should move on to the next one, Julie. But I think we've got a good idea. Thank you, everybody, for sharing. And the chat is also definitely working.
Yes, and good. And we want as much interaction as we can. That was really the point of this. Okay, so the last time that we presented as the child and adolescent group, we showed you our two babies that we're very proud of. And those are the child and adolescent TB guidelines, which is the first update that we've had for 11 years. And I personally, I'm even more proud of the second thing, which was the quick reference guide. So what's really nice with the quick reference guide is that everything centers around this algorithm, where we're trying to assist people in the real world to make a decision with what you have with the patient that you're looking at. And, the quick reference guide uses multiple sources, and this is really to try and make your decision-making quick and easy. So we had some nice patients that we used for that presentation, but unfortunately, the patients that live in my mind are really great. They take their medication, they have exactly the right signs and symptoms, and that's not really what we find in the real world. So I've got 5 cases for you today that were all shared with me via WhatsApp for shared care, and they don't necessarily stick to the rules. So we want to look at and how can we use this guideline to be really practical and accepting that sometimes we don't have all of the answers. So as I mentioned earlier, if you see a question that's orange, it means that a poll is coming up that we'd love your opinion on. And if it's in purple, we'd love you to just respond in the text, and then our moderators will give us a clue of what's going on there. So our first patient...
Just before you jump in, maybe just also to say to everybody, because we have such a wide range of people joining, I really want the nurses also don't feel, we really have tried to make the cases as practical as possible so that even at lower levels of care, you can learn what are the things that Julie needs in her message, or one of the senior doctors needs in their messages when you refer patients, so that they can give you better advice. So we'll try to really cater to all the different disciplines. Thanks, Julie.
Sure. Okay, so the first patient I've summarized because it was quite a wordy message, but this is an 18-month-old female who is living with HIV, and she's got a CD4 that's 20%. She's interrupted her ART at 7 months, so she's had most of her life off of her ARTs, and she doesn't have any known TB contact. So she's now come to the facility with a history of a cough for more than 2 weeks. Her weight for age is on the -2Z score. She's got a cough, she's got transmitted sounds, but no wheezing, and she's not distressed on examination, and there's nothing else of concern on examination. She has had a gene expert taken on, I don't even know what sample. I think it was probably a gastric aspirate, and that was negative, and the culture is still pending on that sample. So the question here is that this person recognizes that this is a child who's at very high risk of getting TB iris if we get this wrong, but she's not really sure if this child's got enough to call it TB. So for those of you who don't know what TB iris is, that's something that occurs in children who have had poor immunity, so either because of HIV or malnutrition, and they've actually been harboring TB for a long time, but haven't been able to respond. So as soon as you switch that immune system back on again, you can have the manifestations of active TB. So that's what this person is scared of. So these are the x-rays of this child. The first was in July 2022, I think just before she went off her ARVs, and then this is the second set in June 2023, and she's not really convinced that there's much to show TB one way or the other on this this x-ray. So the questions I have for you is, what other investigations would you do for this patient that might help you decide if you're going to give treatment or not? And then the poll that's going to come up in a minute is, would you start TB treatment with what you have available to you? So let us know if you're confident to say, listen, the risk is too high. I think this child's been coughing for a while. We're just about to start her ARVs. Her weight's not so great. And I'm kind of a little bit worried about what I'm seeing on that x-ray. Or you're confident to say, no, man, stop being so silly. Or I don't know, I want somebody else to make this decision for me. I'm going to ask Sipho to let me know when we've got sufficient inputs to move on to the answers. I'm going to go back to the x-ray just so that you can have a look at that if you need to decide from there.
Julie, maybe also go to the clinical picture a little bit if somebody's still thinking about that.
So we do have like a few options coming up, but still.
Okay, there's the poll.
Yeah, so the poll is just about starting treatment, but in terms of people that have responded so far, which is not a lot, I think there's about 4 people that have responded. Someone has said urinary lamb, someone has said a mantu, someone also said, let's do another gastric aspirate. We've got more urinary lamb here. I'm not sure. So that's what we have so far.
Perfect. Okay, well, let's move on. So I think in this case, the most useful tests you could do would be a TB skin test. So I think that's really underutilized. This would be very, very helpful in this patient because that would show you that the child has definitely had TB infection. And just a reminder that because this child is HIV positive, we would accept any response above 5 millimeters as useful in this child. If we knew that this child had a TB contact, this would not be adding any additional information. But in this case, we had no known TB contact. So a positive TB skin test would make me very comfortable to treat this child, as well as a urine lamb test. So she qualifies for urine lamb, and that's helpful enough. So I did see Sipho mentioned somebody.
Julie, do you want to talk a little bit? Do you want to talk a little bit about, someone has mentioned a stool expert, and then there's also someone that says, let's do another gastric lavage.
Excellent. Okay, so those could both help. A stool is an okay sample. It's not an amazing sample. So if somebody's already done a gastric aspirate and that was negative, I think it's highly unlikely that we'll get a positive stool on this patient, because the best test was the gastric aspirate or a sputum. And if that didn't even help us, the stool is very unlikely. So you could argue that you'd want a second sample, but the reality is that the laboratory tests are very, very low yield for children. Even a child who's definitely got TB, and you can see it because they've got a contact and they've got all of the signs and symptoms, they've only got about a 35% chance of having a positive test at the lab. So unlike in adults, you just can't rely on the lab. You need to build the whole puzzle. You've heard us all saying that multiple times. So I think that these 2 tests would add puzzle pieces. They might be negative and then it doesn't help you. But if they were positive, it really would help you. So I mean, if you've got the ability to do another gastric aspirate and you've got the time, then you could do that. But also just to be sensitive that this is a child who needs to start his ARVs. And the longer we delay with the story about should we start TB treatments or not, the longer we worry about we delay what he really needs, which is his ARVs. So we said, with what you have, would you start TB treatment? So what's for TB treatment here is this is a high-risk individual. The weight trend, who knows? It's a -2. I don't know the trend of the weight. Maybe that's actually a very good weight for this child. Maybe that child's lost weight. With the information I was given, I don't know if that's TB related or if it's HIV related or if there's something else. The chest x-rays, unfortunately, were terrible quality. And it really looks on the chest x-rays like the heart is quite big, but that might be just because of the poor quality. So I can't really comment on what's going on in that hilum, or if the heart is really the reason that the child is coughing. But it's also hard to say because there's quite a busy right middle lobe. And if I really squint properly, I think I can maybe see a gone focus, and I can see it on sequential chest x-rays. So I'm not really sure about that. I think if this was a gone focus all along in 2022, in a child who's got HIV and is not on ARVs, this child should be a lot sicker. But I can't not see that this x-ray doesn't look entirely normal. So then it brings the question of what will I do next? Do I think it's the safest option to treat the child? And then we can get going with those ARVs in 2 weeks, and maybe I'm over-treating? Or do I think that there's sufficient doubt that this is TB, that I can confidently start ARVs knowing that I'm not going to get an iris? So I don't think we do have a right answer here. But we also know that we have to start this child either on TB treatments or TPT, because this is a child with HIV. So this child is going to be getting something either way. It might be TB causing the symptoms, causing the weight that might or might not be that great. Remember, this child was coughing for more than 2 weeks. And it does look like there's something going on in that x-ray. It could be pneumonia, it could be anything. But I've got 2 sets of x-rays, neither of them looks completely normal to me. So unless some of the other tests that we asked for, either a urine lam or a TB skin test, or maybe if you've got the ability to repeat a lab test, unless those give us a definite yes, I think I would probably treat this child. Not because I think that this child necessarily has TB, but because I think I can't risk it in case the child has TB. So you also know that one of the exciting things in the new guidelines is we tried to have a look at who would be eligible for shortened treatments. So who could we potentially give 4 months of treatment to instead of 6 months? In this case, because this is a child who's living with HIV and is not he's not even on his ARVs, he would not be eligible for treatment shortening. So just a reminder that would be 6 months of treatment. The current guidelines ask for 4 drugs in those first 2 months and 2 drugs for the continuation phase. And don't forget to give him that top-up dose of dolutegravir, because rifampicin doesn't play well with ARVs. Okay, I think we'll leave questions till the end if everybody agrees, and we'll move straight to...
Maybe, Julie, but just to say, because there are 2 quick questions that I think is relative, is actually important as well. So Sue asked what do you think about the impact of recent BCG on TST? And then also around the TST being a test, from Janet, would you treat for TB disease based on a positive TST and no other confirmation? And I think it's just sort of weighing up that the TST is just one piece of your puzzle. And obviously you would not only treat based on a TST, but it gives you a little bit more information on your puzzle on how to decide to treat. But I don't know if you wanted to add anything there on those 2 questions.
Yeah, I think, we don't really know how much impact a very recent BCG would give. So, if we had to do a TST on a 6-week-old baby who's just had his BCG, maybe not. We know that that's the most common reason to have a false positive TB skin test would be a BCG vaccination. This is an 18-month-old child, so it's not that recent. Could still be a false positive, but that's the reason why we allow any reaction at all. Our cutoff is 5 millimeters, so if we've got 4 millimeters of reaction, we say, oh, that's probably from your BCG, and we've got the cutoff of 5 and 10. And of course, those, the body doesn't know, oh, I better be 5 or I better be 7, but that's just the cutoff where we think we're playing safely. And then the question on, would a positive TB skin test alone be enough? Probably not. But in this case, we've got pre-test probability. We've got a high-risk patient who's an HIV positive child not on treatment. We've got an X-ray, which is a bit neither here nor there. And we've got a child who's been coughing for 2 weeks. So for me, I would very confidently treat a child with that high risk, pre-test probability, and a positive TST. If it was some child at a creche who's got nothing wrong with him and we do a positive TST, then we'd have to decide, are we going to give TPT or are we going to give TB treatment? Because all that shows me is exposure with, as you mentioned, a high risk of maybe just a BCG overreaction.
And then the last question, and then I think we do need to move on, was this baby on a course of antibiotics before? And Angelique, I think that's a great question. And I think that's what Julie alluded to before, that this patient is not a definite yes or no patient. And if it's a patient that you were happy to, potentially were able to follow up, you were happy that they would come back, you could consider maybe giving a course of antibiotics and review. But in this case, the child already previously were lost to ARVs. So there's lots of challenges. So I would just make sure that we don't lose the child potentially. But I think this is one of those cases where there's not a definite answer and you can potentially go either way. But I would definitely not treat the child and not follow them up. I would definitely keep a very close eye on them. And as Julie said, I think the biggest thing is we want to start ART as quickly as possible. Yeah.
But I think Angelique's also raised another thing of like, I don't know, this is what I got. So when you are, especially as the nurse, if you are giving a patient forward and your doctor's going to want to know that, have you tried antibiotics? So I'm sharing them exactly as I got them. I don't have all of the information. Okay, so this is patient number 2. This is a 2-year, 6-month-old little boy. He is HIV negative. And his immunizations are up to date. He's never had TB before, and he's never had TPT. But he's living with his uncle, who was recently diagnosed with RIF monoresistant pulmonary TB. He had 2+ smear positive AFBs, and he started on a long course. This was sort of when the regimens have changed a little bit since then. But his uncle was started on long course because he had bilateral lung involvement. So the uncle was pretty sick. And he culture converted after 1 month. And he was currently on month 10 and on treatment and compliant when this baby came into the picture. So the boy was seen 3 months after the uncle was started on treatment. And he was well at that time. He was asymptomatic and he was gaining weight nicely after a period of having a plateau earlier in his life, okay? He started on levofloxacin prophylaxis and he defaulted the levofloxacin prophylaxis and he didn't ever go for his chest x-ray or his gene experts at the time of, when the uncle had only been on treatment for 3 months. He's never been to hospital or the clinic since then. So now it's been a year since his last exposure because the uncle was no longer TB positive. And now this is the x-ray when the child has arrived back. So in summary there, we've got a RIF-resistant TB as the index. He was severely sick at the beginning and infectious when this child was in his midst. The contact lived in the same premises, but not the same house. He was seen 3 months after the initial contact with the uncle, had a workup where he was just clinically examined, looked like he was doing okay. The chest x-ray that I see now, the doctor didn't feel looked like TB. And he was started on levofloxacin TPT, and then he defaulted his follow-up chest x-ray. Sorry, you saw the initial, I'm going back to that. That was his initial x-ray when he was seen at 3 months after being exposed to the uncle. But then he never really went for his follow-up chest x-ray and he never had any testing done. So the interactive questions, this should come up as a poll. Would you consider this significant contact? So the child is sitting with you now. The last time the uncle was infectious was nearly a year ago. It was 10 months ago. And he doesn't live in the house, but he lives in the same yard. So would you consider the significant contact, yes or no? And then the second question is, do you think this was the correct TPT to initiate for this child? So he had the uncle had RIF mono resistant TB. Do you think levofloxacin was the correct answer? And Juaneta, you're going to let us know when we can move on.
We've got 19 responses, waiting for a few more but so far we're getting like 82% yes, 17% no on 28 responses. That's climbing up quickly. That's great. Getting a thumbs up also. I think we're at 34 responses now, Julie, and we've got 85% resounding yes and 14% no for the first question. We haven't put up the second one yet. Is this a significant contact? So perhaps you can speak to that.
Okay. Sure. So I agree. I think that certainly is significant contact. Remember that in the South African guidelines, we don't only talk about household contacts. It's anybody that you've had significant daytime exposure to or slept in the same place overnight. And if you're living on the same premises, often there are kitchen areas and sort of social areas that are shared. So I totally agree with that. Remember that we're interested in, were you in contact with this person when they were infectious? And this child we know was exposed, and lucky for him that he's gone a year with, sounds kind of like not really any real TPT. We would still consider that significant contact because it was more than a year, it was less than a year prior to the day we are seeing him today. Okay, so what are we seeing with the correct TPT choice? What would you give a child who has RIF-resistant exposure?
Also want to give them a bit more time. We're on 24, encouraging everyone to vote, even if you're not sure.
I'd love you to vote on this one, because what we really see is often it's like, oh, I don't know what to do here. I'm just going to refer to the doctor. And then exactly what happened here. This child was referred to a hospital and just never showed up. So we really like you to be able to make the decision or ask so that you can make a decision right now for this child while he's in front of you.
And the responses are anonymous. So if you're really not sure, rather say you're unsure. Then we actually know that maybe we need some more training, or there's better ways that we could guide people going forward.
Sue's also just asked about the index patient. So perhaps, Julie, you can go back to the previous slide where there was a bit more detail about the index patient. And it says confirmed, yeah.
So I was told RIF monoresistant TB, but I'm giving you exactly what I got. But I do talk about that in a moment, Sue, on what the options would be.
We've got 37 responses so far. I think it's sort of tapering out now. And we're looking at about 52% saying yes, 31% saying no, and 15% saying not sure. So less balance than the last question. And I think Sue's also asked a nice question about, do we know if the index patient is also INH resistant? And I love that you said, this is what I got. So if you're okay with me adding here, if I was in Julie's place and I was looking at this WhatsApp, I would have asked, please show me the results and let's go through them together. And if you're the person sending the WhatsApp or asking these questions, then the best thing to do is to go on NHLS, LabTrack, find the patient's information, results, and look through everything. Let's see if there's a culture. Is there a positive gene expert or Roche or TB NAT? Is there a positive culture? On that positive cultured isolate, have we looked at INH and fluoroquinolones? And so, yeah, it has also added, we need to find the uncle's full lab results. And I just want to encourage everyone to make use of LabTrack. If you're struggling with the name and surname, or it's quite an oddly spelt one, or it could be misspelt, you can click the SoundX option on LabTrack that allows you to get a lot of results that look similar to the name. And then I'd really recommend that you go to location and put your location where you think the patient is. Otherwise, you're going to get hundreds of results from the country with similar names. So those are a few tricks you can use on LabTrack. Another good avenue would be to contact we're looking at DRTB here, so to contact the local DRTB hospital or decentralized site. I found that the nurses working there are very good at remembering all their patients, and they can also access EDR if you don't have access to edr.web, where they're allowed to pull up all these results. So excellent points about making sure that this is actually RIF monoresistant TB. I'll let Julie add to that.
Yeah, I think those are all really good if it's a very difficult decision. But to me, this is not a difficult decision. we've got a great drug. It's called levofloxacin. Start the child and let's get going. Because unfortunately, it's easy for us to say, oh no, you should do this and you should do this and you should do this. This nurse has got 45 patients waiting to be seen next. If we know, you know, we obviously want to make sure that the uncle is not levofloxacin resistant, but he's responded to his treatment. So I also think I totally agree. We want as much information as we can practically get, but the practical answer here is start the child on TPT or on something, right? He needs to be started on something, and we don't want to delay or refer or anything like that. But absolutely, we'd always like the best information we can have on the patient. Okay, so before we go into the detailed answers, I'm giving you 2 more questions. So the third question is, do you agree that there is nothing significant on this initial chest X-ray? So this one, I mean, it's not fair to ask the nurses to answer this. I'm only going to ask doctors to answer. So if you think this is an okay X-ray and you don't think it's significant, then you can say, yes, I think this is normal. So yes means you think it's normal, no means you think it's abnormal, and not sure means you're not sure.
Just waiting for more responses.
Yeah, and if you've already responded, I'm going to tell you about the next poll that will come up after this one. But should this child have gone to the hospital instead of the clinic before the decision was made to start the TPT? So if you think the child should have gone to the clinic, to the hospital, you prick yes. If you think this child was managed at the right level of care, you press no. And if you're not sure, you press not sure.
So we've got about 26 responses, a little bit more unsure, I guess. But we've got 55%.
We've eliminated our nurses.
Yeah, maybe it's all the doctors. Yeah, good point. So we've got 55% saying no, nothing significant, 29% saying yes, and 14% not sure. So again, a little bit more balanced out or spread out. Okay. I think, I mean, I'd like Julie to also say, but I think personally, I'm really glad you put this in, because I find that there are x-rays that we read. These are the kind of x-rays we read where I find 2 clinicians will say 2 different things. So Julie might say, I think there's something, and I go, I don't see anything. And I think this is why this is a good case, where I think you could argue that you see something, for example, in the right mid to lower zone on the AP, but maybe those are vessels. We need to look at rotation. Maybe it's slightly rotated and penetration. And so it's kind of one of those things where, yeah, it kind of looks mostly normal. Is it? We're not sure. I'll let Julie say what she thought as well.
Well, I think if I was really hunting for something, I would maybe look at that left upper lobe. It sort of looks like there's some speckling there. But the rule of x-rays is always checking the quality first. So this is a very an underexposed x-ray. I can't see... I mean, in the middle of this X-ray, on my view, when I'm looking at it right now, I can't see the intervertebral spaces at all. I can't see the airways very well at all. So if the quality is poor, then my answer is going to be poor. So I don't think it's not terrible. It's not the worst X-ray I've ever seen. And I think on my actual WhatsApp, it looked a little bit better. But quality matters more than these, oh, yeah, like, I remember maybe whatever. I don't really see anything on the lateral. But exactly as Juaneta says, I mean, what's scary is if I go back to these cases and I disagree with myself from what I said the first time. So there's a lot of subjectivity. Okay, but let's move on. So
should we go to the next question?
Oh, we haven't done the poll. Okay.
Yeah. So the 30 responses for should they have gone to the clinic before starting TPT, to the hospital before starting TPT, and 19% said yes, 61%. So the majority said no, and another 19% were not sure. So the question is about whether can we make a diagnosis of TB in this particular child, or make a diagnosis of not TB, we can start TPT at clinic level. Personally, because we're trying to push that this can be done at clinic level, definitely it can be done at clinic level from my side. And I think that's because, I mean, we have X-ray, we've got symptoms, and we have in our national guidelines, if the child is asymptomatic and completely well, and you've got, you know, you've investigated them as you have here, you can actually start TPT without delaying. And the big issue, I mean, it's exactly what happened with this child, is they get referred to a hospital and then say it's far away, or they just can't make it there. They end up not going, and they end up actually just getting on nothing. And so even while you're looking for the details of the contacts and getting someone to read the X-ray with you as well, you want to just start something. 2 or 3 days of levofloxacin that gets changed to some other TPT or additional TPT. It's not going to be an issue, but you want to start the child on something. And you can always call for advice, but this can really be done in primary care. Judy, do you want to add?
Yes, I'm stealing a quote from somebody from the Tshwane Metro. I love this quote. It's that sometimes the question needs to be referred to a higher level of expertise, not a higher level of care. So that's exactly what the WhatsApp group and shared care is I don't know the answer to this. I'm asking for help. It doesn't mean the patient has to physically be moved to a different area. Maybe there's a doctor who can help you, who's just sitting in another room in your clinic, or you can ask for advice without actually expecting the patient to move. The second the patient has left your facility, there's a big risk that they never come back. And you haven't done, you know, you might be too scared to make the decisions, but you can always try and get that decision making made where you are. And a patient who leaves the clinic with a packet of medication in their hand is more likely to actually come back than the patient where you said, I don't know, somebody else will decide and tell you what to do. So I totally agree with you on that one. And I love the 61% of you who said this patient could be managed at a clinic, because that's exactly what's appropriate for a child who's a contact. Okay, so do you think this was significant contact? We've pretty much covered that, that this would count as significant contact. And there's a nice page in the quick reference guide on which TPT you would choose. So levofloxacin is the TPT of choice for RIF-resistant TB, even if we're still waiting for levosusceptibility from the index. Okay, the more we wait, we can always change our minds later. But if you send the patient home with nothing, they often won't come back. So that's what we would start them on. If we are 100% certain of INH susceptibility, we could consider INH. But just remember that with the current testing we have, we can only pick up 90% of INH resistance patterns. So I feel much more comfortable starting a child on levo than on INH. Okay, so the methods that the lab has, unless it's culture susceptibility, you know, they might miss a few. So I'm personally, you know, you can be more of a gambler than me. I like levo for RIF because I know I'm 100%, well, not 100%, but close to 100% sure. Okay, do you agree that nothing significant on the chest X-ray, as we sort of mentioned, yeah, maybe if you really want to see something, but quality was more of a problem here than pathology. Should this child have gone to the hospital? No, 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 no. This was an excellent referral. This person did a really good history. They examined the child. They looked at their growth assessment and what's going to be done differently at the hospital. Nothing at all. This is exactly what would have happened at the hospital too. The only criticism I would give for the PHC is that this would be a patient where it might be helpful to try and get a specimen. Even in our guidelines, we actually say it's not necessary. This child was growing well. They don't need to give a specimen. It's probably going to be negative anyway. Okay.
Just to add, Julie, I like this point that was made previously by Janet. It would be good to know why the child did not continue TPT. So that just adds the social aspect of our history taking when we see participants or patients. You know, if they haven't taken the TPT in the first place and you're starting it again now, we need to make sure that they can take it now. And so it's really important to address social issues and whatever may have led to the initial interruption of prevention. So that's a very good point. And Sue asked about 100 milligram child-friendly formulation readily available at clinic level. It is not currently available. It is available occasionally in some of the DRTB hospitals, but there is a dosing chart in the quick reference guide. There's a little chart for what to do with the 250 milligram tablet that can be broken in half, and for one weight band it's crushed and mixed, but otherwise we use half a tablet or a full tablet crushed and given. And just to add, I mean, we're thinking about children here. It doesn't taste nice, so whatever you can do to encourage the child to drink it, similar to the old days when we used Calitra, whether it's giving a bit of peanut butter afterwards or a spoon of multivitamin or 5 mils of multivitamin, think about what's going to affect compliance going forward, just as Janet mentioned. Thanks.
Great. Okay, so the reason that this child has come back into care and why I was getting messaged about this child in the first place is now the child's come back 6 months later with static weight, known food insecurity in the home, and this person thought to look for other causes as well. He's got a normal HB, he's got a normal TSH. I don't know if I would have gone that far, and also had a normal CRP. The child is clinically well. It's not really that clear why they returned, because you generally we worried about weight, but the family doesn't usually pick up that their child hasn't gained weight. So I'm not quite clear why this child suddenly arrived, because he was clinically well and had no symptoms. And it's also unclear if he actually ever had any TPT. Just because somebody prescribed Levo, I think we can basically count on this child getting a month at most, but probably no levofloxacin at all. The chest X-ray 6 months later, to me, again, looks pretty normal. I'm still seeing some little flicks in that left upper lobe, and this is on the second X-ray, so that's a little bit concerning. But again, this is like 6 months later, the child is still not sick. If that was TB from 6 months ago, I think something would have developed by now. At this point, the child has had a gene expert and a culture that are both negative. So the question then is, what would you do now? So would you restart the levofloxacin, considering he's pretty much had none? Would you start RIF-resistant TB treatments? Would you say, I think this is a bit too early to say and we maybe need some more tests? Or would you say that you're not sure? And I'm going to fill in on the poll, and I actually think it's something different to what I initially thought, because I changed my mind when I reread these things. But also that there's not always one right answer, right? I don't know. I don't even remember what I said, but I think actually, no, I think I'm going back to my original answer.
So just to clarify, this is the same child, but now we're looking at what's happening right now. 6 months later, he's come, there's static weight, this is the X-ray, clinically well, the findings are here. We're looking at 15 responses, encouraging others to give it a shot. No one's going to know.
Remember, this is a hard patient, right? We don't want to give you the easiest patients. We are going to have to move a bit faster. We've only got 15 minutes left.
Yeah.
Janet, I see your question. He has had a gene expert and it was negative, and the culture was negative.
So I think we'll, for the interest of time, we've got 20 responses and it's pretty balanced. So 33% think restart TPT, 13% think start treatment, 34% want more tests, and 17% are unsure. So it's pretty spread out with more people wanting to do TPT or test more.
Okay, that's fair enough. So I think just to say, like, none of us are sure, right? So in a way, we should all say not sure. But the question is, what would you do? Not does this child have TB? So I think we aren't sure, but we need to make a plan. So in a way, not sure is true for everybody, but it's also like the least, the option we can't really accept. So I think what we need to look at is we really would like some more tests if possible. But the thing is, what tests are we going to do? He's HIV negative, so we could maybe repeat that HIV test just to check. But a TB lamb, a urine lamb is not helpful here because he doesn't qualify for that. A TB skin test is not going to be helpful here because we already know he's got a contact. So if it's positive, it still doesn't differentiate between disease and infection. And I think the problem with this child is he's already shown us that he doesn't show up when you refer him. So maybe there was a specific reason, maybe there was a particular caregiver, but I think that the benefits of making a decision right now in this child would probably be helpful. We have already got a sample taken that's come up negative. So we can repeat, and then we can also repeat again and again and again. But the best sample you're going to get is the first one. And I don't know if this was a sputum or what this was. I wouldn't, if we've got a sputum, that's superior to stool. And when we're talking MDR, and we're really talking quite a big difference in drug regimens, I would push a bit harder to try and get a specimen. But once I've got one specimen, I don't think going for another one is necessarily all that likely to help. So what we could say here is like, look, we've got a known reason why this child might be failing to thrive. Should we deworm him? Should we try and assist a little bit with food insecurity? But I think we kind of need to look at at the old extras and the new extras. So I think the clue here is you've got the advantage of looking at the past and looking at the present. So we first of all have that in the chest x-rays. So if you look at them side by side, I actually think that one from 2022 looks a bit worse than the one from 2023. I do see some little speckles on that side, maybe. I don't think that that there's really much on the AP or the lateral that scares me particularly. I think if this is TB, it's minimal disease, and we've got that guideline for you if you aren't sure in the quick reference guide to have a look for yourself. So I think for me personally, the thing that's worrying me is that there are those little dots up in the corner that stay there. So those could be scars from something else previously, but I don't know if I would say this is an absolutely stock standard normal extra. I'm just not sure is my answer. Maybe someone's more confident than I am. So the thing that we also can use to compare the past and the future is this road to health card. So remember, this was a child who previously was plateauing. So if you look at that at 6 months, right? So he'd had a really bad weight there, and he was actually gaining by the time he was seen 3 months after the uncle started treatment, at 11.1. So I understand when that child came in and weighed 11.1, just after the treatment started the uncle started treatment, it makes sense that they said, no, this child is not failing. But what do you think now? And this is real, by the way. I didn't make this growth chart up. This is what was sent to me. So this is really what the child's weights are. And I think in this case, it really makes it's going to be very, very difficult for me not to treat this child. With the maybe this, maybe that, the chest x-ray, well, I don't really know. The lab was not helpful in this case, but with 3 months of consistent weight loss, we can try and give him a few months of nutritional support, but to me, this looks pretty convincing that this child is really failing. So I would not take that chance. For me, very bad weight loss, a child who's got a significant contact, a child who's got failure to thrive, and he actually had been given NTP, and it wasn't helping. And the doctor had looked for other potential causes. I don't think he's had TPT, so he's had no protection. Maybe there's some specks on the left upper lobe. For me personally, I would feel very uncomfortable not starting this child. But I think what I really want to highlight here is I don't know if this child's got TB or not. I know that I want to start treatment. And that's sometimes a very uncomfortable position to be in, but we've got to look at it, the risk of treating versus the risk of not treating. So I would have started this child on treatment at this point, but I mean, it was a questionable diagnosis to begin with. So he certainly would be non-severe disease, and I would notify him as clinically diagnosed, because the real clincher for me was actually the weight trend, not anything else. And the lab, unfortunately, couldn't help us out here. So you can see that you don't need to know too much detail about the regimen. That's all in the guidelines for you. But we know that usually it's the decision on, am I going to do it or not do it? That gets us there. We're running very behind. I'm afraid I'm going to see.
Yeah, we need to get cracking. So we've got 10 minutes left. I'm wondering, after 3 patients has left, is there any? I think we only have time for one. So maybe
let's do this one. Yeah, let's do this one. We can always do it. I can add 1.5 to later ones then.
Okay, and then if everybody, just reminder, there's a CPD attendance register in the chat. So please just fill that in so that you can get your points.
Yeah, and if you want to, if anybody wants to say, I'm happy to do 4 and 5 if we run out of time. But that's fine. It's great we've had such good responses. So this was a message I got from a nurse, and she said she's got a 3-year-old with an AFB positive contact, which is the dad. The child starts at INH 150 milligrams last week, weighing 12 kilograms, and was given 12.5 milligrams of vitamin B6. But now the mom is complaining that this child is walking funny and rubbing her feet. To what dose can I increase the INH, or what is plan B, please? So, interactive question. Would you have managed this child in this way? So this is a child who, I'm going to make the presumption that the contact is RIF susceptible. So would you have managed this RIF susceptible contact with INH and vitamin B6? Okay, and that's quite a straightforward question. So I'm going straight on to the questions we'd like you to answer in the chat. And that is, what might be wrong with this child? What is this nurse describing? And I'm giving you a clue. There's more than one option here. And then the third question, you can tell us in the chat, is what should the nurse check to assist to make the correct diagnosis of what's going on here? And I'm telling you, it's a nurse, okay? This is not something fancy that doctors need to do. Nurses can do this too.
Yeah, so I don't know what, well, unless, yeah, so the answers are coming in a little bit slower than before.
Okay.
I'm not sure why. So we've got maybe about 15 people that have responded, well, 16 now. So most 66% agree with this management. So would you have started this patient on INH and B6? So most people say yes. 22% say I would have started something else. And only 1% says I would not have started anything.
Okay, that's interesting. I'd love that person if you're brave enough to tell us why you wouldn't have started anything. Maybe you've got a good reason for that. So here's the shall we move on? Or do you want to is there anything on question 2 and 3?
I'm worried about time, so maybe let's just chat a little bit about that.
Okay, but you can still keep filling in the answers, people, on what might be wrong with this child and what should the nurse be checking to make the diagnosis. So in this case, INH is totally acceptable, but that's a bit mean to this family who has to come in for 6 months instead of for 3 months. So remember that 3RH is actually a totally reasonable TPT. And the nice advantage with 3RH is that's readily available everywhere because it's exactly the same 3RH that we use for the continuation phase of treatment. It tastes a little bit better. But that's only for children who are HIV negative because the rifampicin component causes trouble with the ARVs. So any HIV negative child, 3RH is a much nicer option than 6H, but 6H is acceptable if that's all that you have at your facility. I think what this nurse was too scared to say, but she was actually saying, is that she thinks that this child's got peripheral neuropathy. And we know that that is one of the side effects of INH. But the trick here is that you shouldn't just jump straight to that assumption. So children who've got extrapulmonary TB can also present with difficulty walking. You've got a child who was one and just learning how to walk, and now this child refuses to crawl or won't weight bear at all. This could be a child who's got spine TB and is having some pressure. And often children with quite severe spine TB, the first thing that actually makes the parents bring them in is when the child stops walking. So we know this is a TB exposed child. We know that we must look for extrapulmonary TB. Even if it's unlikely, it's more likely to present in children than in adults. So always do a full check. But also kids are kids. They're walking around barefoot. They're stepping on glass. They get all kinds of infections. They get scabies. So I think it's also important just to look for some other reason why this child might be walking funny and rubbing her feet. Okay, even a bladder infection. A little girl might be walking in a funny way because she's just otherwise uncomfortable. So what should the nurse check to make sure that we're picking the right one? So always clinical examination. And in this case, we'd really want it to be looking at the lower limbs, looking for any forms of swelling or anything that could show us that this child's got TB of a joint, a good examination of the spine, looking at the deep tendon reflexes, which could also be abnormal if it's INH related. If TB has been ruled out prior to the TPT initiation, so you'll see that this person didn't tell me if she ever assessed if the child needed TB treatments or not. She just told me that I started CPT. So maybe going back to just double check that we didn't miss something there. We always want an HIV test if it hasn't been done. If there are any features of malnutrition, because that could also cause a peripheral neuropathy, and that's easy to correct. And also if this child is on any other medications that could potentially cause the peripheral neuropathy. So most likely it is INH related, but we don't want to miss other things because we're convinced of the first thing that we get. So I'm going to ask you to fill in the chat if you want to, but we're really running short on time, so I'm probably just going to give you the answers here. What would you check for a patient presenting with peripheral neuropathy. So, I mean, all of us are prescribing TB treatments, and we know that it's got INH. We know we're giving the vitamin B6. If your patient arrives and you think they've got peripheral neuropathy, what do you go back and check? And if the above child, if all of these things we're going to talk about now that we'll check are all normal, what would you recommend next for this child and this mom who've got a bit of a problem with their INH? So I think the first thing is always remembering that you're giving the correct dose for the weight of the child, checking that what you've decided the child needs is actually what you wrote. And I'm sure I have, and I'm sure all of you have at some point left something off the prescription or added a zero, put a comma in the wrong place, or just written badly where the pharmacist couldn't actually see what you wrote. So is the dose correct? Did you prescribe it the right way? Is what you prescribed actually what the pharmacy gave, or did somebody not read your handwriting properly, was a bit distracted and gave something else, or just left it off completely because they didn't have stock? And if what you have was, if you actually issued this, asking the mom what she was given. So in this scenario, if dad's got TB, both the mom and the child would be eligible for TPT. So is mom maybe mixing up who's getting, maybe she thinks, oh, me and my child are on the same medication and she's getting